City Saimer, Dayanand Sagar University. Sir, take over. Request scientist, Director, Research Department, ICM.
Ladies and gentlemen, a very good evening to all of you. We're coming to yet another very interesting session. I'd like to introduce our speaker, Dr. R. Balaji. So Dr. Balaji's special interests are in clinical trials and implementation research. Special interest in tuberculosis, community medicine, and allergy and immunology. He has over 110 publications, and he has been a part of over 15 regulated randomized clinical trials, especially in vaccines, and 20 field-based trials. And his research also includes translational research in vaccine trials on rotavirus, Covaxin. You know how important Covaxin was, and it played such an important role during COVID times. And he has been a part of accelerated TB elimination in India, TB elimination in the SEAR countries, and he has been a part of several ICMR projects. Dr. Balaji, a very, very warm welcome to you. Please carry out with the sessions. Thank you.
Thank you, sir. Thank you for that introduction. Good afternoon or good evening. Are you all with me? I could not hear any voice. Okay, or I should ask, ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ ಹಂಗಂದ್ರೆ ಬರುತ್ತಾ ಓಕೆ ಸ್ವಲ್ಪ ನನಗೂ ಕನ್ನಡ ಬರುತ್ತೆ because I started my research career just 40 kilometers from here in Bangalore. That's where I did my MD, and most of my mentors are also part of the academic council over here. So good to be here. I'm just stunned to see the institute, the campus, the clubhouse, the stadium, and the backdrop. Everything looks more like a cultural program arrangement, but a conference is having such a big thing is really nice. And so let's go to our topic, multidisciplinary collaborative pathway for accelerating TB research. So many of you even would have thought, do we have TB problem in our country, right? So the moment we say TB, we think still TB is there. We are speaking about heart disease, diabetes, hypertension, but there's someone who's coming and speaking about TB. And let's see what's going on with TB with further slides. So the title says, need for accelerating research in TB. So why, collaborative for accelerating TB. Why do we need to accelerate the research in TB? So this slide, even just now I noted, it has this Bangalore word also inside. So when I landed in Bangalore, I thought I can easily reach Dayanand Sagar, thinking the campus within Bangalore. Then I realized I have to travel another 40 kilometers to come here. So we should be very clear where we stand, how we are going to go forward to achieve something. So if you look at this, okay, this is last year's global TB report. In fact, if you browse 2 or 3 days before, we even have the 2025 report being released, just 2 days back. There's a fair amount of contribution by India being the TB capital to the entire world. So TB is nowhere gone. It's very much within ourselves. If you look in our community, you can easily find for every 1 lakh population, how many cases are coming out and how much we are contributing. Look, in the last column, you can see nearly 10 to 25 in each type of TB, the burden which we are giving to the entire global level. Yeah, when you look at this global perspective, WHO says that we need to end TB. This is a common logo which you see whenever we speak about TB. The entire world, including our country, if you look at our Honorable Prime Minister Modi ji, he said that TB has to be eliminated in India by 2025, but we were nowhere near that. So we are going to finish 25 and nowhere. So it's still going on. So end TB is a target for us. The global approach has a multi-pronged approach with various initiatives various policy makers, stakeholders coming together to work towards this NTB. Just look at this graph, where we stand. Look, the 100 rate per 1 lakh per year, whatever. Okay, if you stand at 100 now, okay, this was made in 2015. And if you have to reach to the lowest level of 10, okay, imagine 2025, it's not going to be possible with the present trend. Where we stand, we don't even touch 75 or maybe 65 something. Okay, if you look at this approach which you have in between, okay, so multi-pronged approach which is required from various disciplines. As a doctor, it's not just my role to do whatever is right. It's all you people, every discipline who should come inside. Sorry, I could not use this pointer. Who should come inside to apply these various interventions to change the curve to a much lower level, to say we are going for NTB or elimination. Fine. So even before going to the approach, first you should understand what are the barriers we have as doctors or clinicians or any health sciences people when we come to TB management. Number one, delayed diagnosis, longer treatment regimen. There was time where people have to take minimum 12 months treatment, 18 to 24 months treatment for drug-resistant TB, and it's all quite long. And we always say we don't have enough drugs in the pipeline, so whatever we use, resistance is coming and we are in problem. The outcomes are not uniform everywhere. People don't take tablets regularly. The adherence is poor when it comes to TB. Imagine taking 6 months or 9 months, so we'll see where we stand. Lot of recurrence. I treat a patient with such longer regimen, still so many people get TB. So recurrence is an issue. Lot of social stigma. Even if someone we know that has TB, we'll try to avoid them totally. People lose their jobs. So many issues are happening because of TB. So these are some way why we are not able to remove this problem from our society. And a lot of cultural barriers as well. Just look at the left side. Leave about research. Even for me to go for TB prevention or cure, I need a set of specialists in different areas. Okay, not only medical, okay, paramedical, sociologist, okay, other health sciences, lab specialists, everyone should come in just to treat a patient or prevent someone from getting TB. Then imagine how much of people are required to collaborate to take the pathway towards NTB in TB research. So with this, I'm just going to the main topic, which doesn't say that it should be there only for TB research. For any research, if you want to go it in a fast manner, we need to have a collaborative approach. So what are the advantages of benefit? So many places, whenever people do research, what we understand is we all work in silos. We work separately and we publish our paper and we stop there. Okay? We most of the time fail to collaborate. Even before joining ICMR, I was working like that. We failed to collaborate with our interdepartment people to take things forward. But if you want to achieve something and if you collaborate, what are the benefits? There is an enhanced creativity when multiple people come. The access to resources are better expertise is there. Publication and the citation factor is increased because enough application happens. Accelerated progress and a strengthened networking. So in the morning session, I was watching on YouTube. One of the senior management person from here said, DSU, Diana Saga University, is having projects where TRL 1 to 9 you're reaching, and in fact they're going to 10 based on sustainability. I was really happy that at university level people start thinking. It's not only at ICMR or some higher level people. So good things are going in good direction, and one such way to go is this collaborative research. And whenever we say collaborative research are required, we always have certain side enablers and certain challenges. If you have a carefully planned research projects or implementation project, meaningful engagement with various people and adequate resource, these are going to enable our research output. On the other hand, if you look at the challenges, okay, there are lack of data information sharing. So India, they have restrictions, we won't share it outside. one institute has restriction, they won't share it to others. So those things, then continuing the relationship, the cultural practices, like that, you can see multiple challenges which are going to be hindrance for any collaborative research, which you should think prior before framing your research partnership. So how do we collaborate? We need to think a lot. We need to bring our brains together to make sure this collaborative research works. So there are certain types of collaboration which as youngsters, many of you I can see here, as you keep growing. So I said, when I did my PG, for the first time I heard research during my MD. Okay, but today I am in a position where I can demand certain things in research, working as a scientist in ICMR. Youngsters behind can come and end up in such high institutes, either ICMR, DST, DBT, but you should have a broader thinking when it comes to research. So the collaboration can be within an academic institute. Either you can collaborate or one institute can collaborate with others. So collaboration with other academic institutes like DSU can collaborate with medical universities or wherever possible. Collaboration with a government entity. So any research, for it to be successful, for it to be translated, okay, we don't stop only till we get publication, only till we write a report. We want our efforts to be converted into an action, into a sustainable manner for the benefit of the people. So whenever there is a chance to collaborate with a government entity, please try to do that. Collaborate with private industry. Many pharmaceutical companies and many other private partners are there with whom your collaboration can come to a major institute. In fact, I think this conference would be a success because of such collaborations even with private industry and collaboration with international researcher. From morning I have been seeing names where international experts are coming and giving talks to the delegate. So it's not only collaboration for conference, for research, if you have such collaboration, it's going to be helpful in a major manner. So with this, now I'm going to use this concept for TB at India level. Okay, so this NIRT, National Institute for Research in Tuberculosis, or previously it's called TRC, it's not very far off. It's hardly 350 kilometers from your place, which is a pioneering institute with anything for TB, majorly clinical trial. You won't believe it doesn't give evidence only for our country. Many developed or developing countries also take our research output. So when we visit other countries or other institutes, when they introduce us, even we'll be shocked. They'll be like very proud saying we have a partner from TRC or NIRT who has given us guidelines for us to do. So India is no lesser in research. India is doing wonderful job, and it's all about our way to approach it. So it's a collaborating center with WHO. It is not only a laboratory which supports at the local Chennai or Tamil Nadu or for our country at national, it is also supranational. So this particular lab is developed in so way that we support research and also facilities at the lab level for other countries. It has an international center for excellence, and yeah, mainly we build evidence for TB management. So some boosting should happen whenever we come from one institute to represent in a conference. So why I'm bringing this point is, when I entered this institute 5 years back, I thought TB research doctors will be doing. And when I entered, there were only 10 doctors who were scientists in an institute of such big manner. And there were another 30 to 40 scientists from non-medical side, okay, from health sciences, from various other aspects, which I was showing previously, and other technical officers who were working on research. I was so shocked to see one disease will have 10 to 12 departments in one institute who work on research. So it clearly says, if you want to do something, if you want to translate something, there have to be collaborative research with multiple people who will be helping. For example, clinical research is something which doctors majorly will be there doing clinical trial. We work both on the treatment aspect, whatever form of TB, and also on the prevention aspect. On the other hand, we also people who are epidemiologists, who are public health specialists, okay, lab specialists who are trained in bacteriology, because TB is a bacilli, the organism is a bacilli, and bacteriology specialists will be there who contribute majorly. I'll also be showing individual contribution which can help you to understand how research is happening in our country. Socio-behavioral research, sociologists come and play a very important role. Immunology, biotechnology, clinical pharmacology, biochemistry, statistics, bioinformatics, health economics. I don't know who among you people will fit in different aspects. You may not be directly from a department mentioned here, but indirectly you may be part of any of the domain. So we'll see in detail how this research happens. As I said, clinical research again doesn't stop only with medical professional doctors. We have staff nurse, we have lab technicians who will be part, phlebotomist, phlebotomist, whatever. Everyone will be again part of the research. Their service again is not counted down, though it's not mentioned as a major domain. So we look at different aspects. Okay, so when we come to clinical, drug sensitive TB, this is how it starts. Our research basic background says we need to focus on shortening this longer treatment. I said 6 to 9 months of treatment, 12 to 18 months of treatment for the advanced form. How we are going to reduce this so that people start taking such treatment. How we are going to find the newer drugs. The drugs that are in the pipeline are very less. How we are going to find this newer drug. Pharmaceutical people, pharmaceutical group is here. They can be part of it in finding out this new drug. If any adjunct therapy can be added so that my regimen works better. And finally, I look whether it's effective and safe. So some state-of-the-art trials which had come out from India, which will be followed elsewhere also. There's one trial which says that this 6 months can be reduced to 4 months. Okay, imagine a person taking 6 months, and if it's reduced to 4 months, obviously he will be taking it better, and if I show that this particular trial works good, then it will be translated. So this is how we start taking it on. Similarly, adjunct therapy. I have set of 4 to 5 drugs for TB. I think why don't I add a multivitamin, something like vitamin C, vitamin D, or an anti-diabetic drug like metformin, which has a host therapy kind of mechanism. If this added with the regular therapy, does it produce a good change? So I do trial and see whether it's working or not. Again, all my teammates like bacteriologists, clinical pharma, everyone comes into picture, whose role I'll be showing in the further slide as well. So when I go to drug resistant, which is a major form, as I said, 18 months, 24 months treatment, again I need to reduce the number of drugs, because imagine a patient taking a handful of drug daily for 18 months, 24 months. Do you think either we will do or we can expect him to do? There's no other option. Currently, that's what is happening. But recently, a game changer has come and people are relatively getting better. So I need to reduce the duration. I need to produce early culture conversion so that he is no more bacteriologically positive. The outcome should be good. You should have less death. Usually 30 to 40% of these people die. I don't want so much of death for my patient. And people will go off without taking treatment. So I need to reduce that part. And some newer drugs or existing drugs, I will have to think about things. This is how all the scientists sit together thinking what we will have to do further. So certain landmark trials here. This is the first trial in India, okay, which said that instead of giving 18 months of therapy, we can go for initially 9 months of treatment. Okay, 9 itself is huge, but giving 9 months and see whether it's going to work for our people. So they brought in certain newer drugs, tried in different stages. People who are into pharmacy will be knowing, right? Phase 1, phase 2, stage 1, stage 2. And they said 9 months is good enough. Okay, 9 months is good enough. You know, in fact, I didn't mention the trial. The landmark trial from NIRT, which has reached the entire world, is a patient can take tablet at home and need not be staying in a sanatorium. If you all look at history, TB sanatorium will be there in many places. But this particular institute from India, along with the efforts of all the experts, said that just taking tablets at home is well and good, and this practice was followed even in developed countries, and now there is no more sanatorium. So this is an advanced later stages clinical trial. This was the trial which showed that you don't need even 9 months. We can even stop at 6 months with the 4 highly effective drugs so that the patient gets benefited. Again, people started looking at this, how to improve the adherence by giving 4 drugs and showing a lot of treatment. And next is my favorite trial. Okay, so when I joined, we started this. It's called Modified BPAL Clinical Trial. Okay, so doctors here or few medical professionals here should be knowing this BPAL, because this particular trial got translated into program, and any patient who is defined or diagnosed as drug-resistant TB is taking this regimen, BPAL-M. Okay, so what we did was, as we said, we went for 6 months. We said we don't want handful of tablet, we want only 3, and if 3 good drugs are given, I can reduce the organism which kills 30% of my patient, 30% who is not taking treatment, and only 40% success, to be at a different level. And this trial showed for every 100 drug TB patient, 90% of them become normal within 6 months with just handful of 3 to 4 drugs in 6 months, daily for 6 months, which was a game changer. And when this collaborative research was shown to the government, it was translated, and now Government of India is using this. Of course, not only Government of India, the world level also it's been followed. So these are some landmark things which you should know. Look at the injections or tablet which a patient had to take, and now he says just 4 or 5 tablets. It depends on the weight to little extent, but that's all. It's easy, no? Like when we take, when we have fever or cold, we take some 2 or 3 tablets. Like that, even a drug-resistant form of TB fellow is taking. That's a boom. Okay, these kind of research works. If it comes, okay, the mankind will be benefited. So when you start thinking about research in your future, think about game-changing research which will bring you fame. There are also multiple research which happens, which I'm not going to touch here. What I say is, when I come to TB, I look at different forms of TB. For each form, I need to work, find out newer regimens and take it forward. When it comes to preventive therapy, there are 2 aspects. One side, immunotherapy, we saw in the past presentations by the speaker. Then chemotherapy also is there. Okay, so immunotherapy means basically, I think everyone have a scar. Do you all have a BCG scar? Should be knowing. If you don't know, then I am not sure. So look at your left arm, unless you're too young, okay? It should be here. Even now we have a BCG thing, right? So BCG scar is there on the left arm for everyone, okay? And it was shown to give minimal effect. It's not a game changer as a vaccine. Till date, if any one of you want to get a Nobel Prize, or if you want to become a major researcher, if you find a proper vaccine with a good effectiveness, you will be a master of this field. So we are trying on different kind of vaccine to have at least 50% effect, not even 100%, at least 50%. But this bacilli is so strong that it's not allowing us to give out a possible a good vaccine. COVID, my name was shown for Covaxin, right? Within months, we got one vaccine for that virus. We even eliminated the pandemic within a year, though it had some catastrophic effect. I mean, the disease had catastrophic effect. The vaccine was a game changer. So every government looks for this vaccine. Somehow, not many vaccines are successful. So NIRT or you people, if you're interested, should be working on vaccines. And not only vaccine, like revaccination, because we already took vaccine BCG. If we give another dose, whether it will work, again, that is a research which will be going on. Yeah, as I said, new vaccine, many candidates are coming. People from pharmacy background, you can work on, come with new vaccine candidate which can do wonders. Chemotherapy on the other hand, not only for treating patient, even for preventing TB disease. Imagine we are all standing here. Someone would be having TB disease, and if he coughs and if we get the infection, I need to have a preventive therapy well in hand so that I don't get the organism. And any of the health sciences people will be having the organism within us. The earlier we kill it or maintain our immunity, good that we don't have the disease, it will be going only as an infection. So a lot of trial happens for different forms of TB to come up with better. So one mention on the top, like 3HP is something again got translated. Government of India took such regimen saying that instead of taking 6 months of one tablet, they said 12 doses, okay, of 2 tablets, around 2 tablets, weekly once for 12 weeks. That's all. Weekly once you take for 12 weeks, and we can be free of this infection. So now people are feeling better. Instead of taking 180 tablets for 180 days, right? So now I'm just taking 12 doses. Likewise, we keep trying out different things with our partners. When I look at field level, so if you look at lot of field-based researchers, technicians, everyone come here where we do surveys to find out what is the burden of TB in our country. TB is, as I said, TB is not less in India, it's too much, it's lot. Though when you look at 1 lakh people and look at other diseases, it might look small, but the way it can spread is different. And if you are going to miss one TB patient, he's going to transmit to 12 more people. Imagine if one person is having TB among your friends and not taking treatment, within a year, 12 more people will be getting that particular infection and disease. So the earlier you find through such prevalence mechanism, prevalence surveys, you are able to do wonders. So if you look at the recent report is released in 2021, which says what is the actual problem in India. It's a very big survey which was given to NIRT to do. Though we are clinical trial specialists, we did this and the huge task happened. So again, here not only a collaboration within our scientists, it was with the government, it was with the private medical colleges through an association, multiple collaboration happened for this 100 crore project. And what I'm showing, nothing stops with the lakhs. It's all in crores. That much of collaboration happened. And I'll just skip certain slide. As I said, people from microbiology or lab technicians, if some group is here, I say one department which is doing wonderful job, even more than doctor, is this bacteriology group who come up with newer diagnostics, develop newer diagnostic, they validate newer diagnostic from private partners, and they validate diagnostic not only with the sputum, with other material. For example, it's very difficult for a doctor to get a sputum from a pediatric child, right? Child will not be giving a sputum like an adult. So I need some other sample to find TB in that. So what will happen, these kind of basic science researchers, they come up saying urine or stool is a good specimen to be tested for TB, and those will be slowly translated into the program. So a lot of research happens here and they support. For example, if I do a clinical trial, for all the conversion and to say that my drug is working, I need a bacteriologist to show that the sputum doesn't have the bacilli. Only if I collaborate with that division, I can show. I can't say, doctor, you're treated, right? Without lab, I can't even treat a single patient, right? I can do it saying that, okay, in my practice, this fever could be this. But if I have a doubt, more than 3 days of fever, I just immediately write a laboratory sample to be done, this test to be done, rule out dengue, typhoid. Similarly, research, lab collaboration is required in lot. Not only disease for infection, as I said, urine, stool, multiple diagnostics are coming up. This is one area I could see a lot of people come for internship to our institute. They do PhD in this area. And I usually feel doctors, we don't grow up that easily abroad, but all paramedical sciences, people who did PhD in these departments, they just go and settle in abroad or major institutions. Not only basic things, some advanced level like whole genome sequencing, all those things are being developed based on not only bacteriology people, also biomedical engineering, IIT people come with us. Multiple collaboration happens to come up with these kind of diagnostics to take it forward. Yeah, just this is what I showed in the previous slide. So who are these people? Social and behavioral research. Why should I have, I finished doctors, I finished the lab people, I'm bringing in a different people called social scientists, okay? Or sociologists, what is their role? So it's easy to say, take sample, do the testing. It's easy to say, this is the treatment, take this treatment. But will the patient take? Will he follow those treatment? I don't know. So these are people who find out what could be the reason why we are not succeeding. So they find out the challenges when we go for the implementation of the program. How to improve the compliance and adherence. How to improve utilization. People know that I have a symptom, but they don't even say, okay. So on an average, if 100 people, if I check, at least 3 to 4 people should have symptom. But when I conducted a similar kind of research in Delhi or few areas, not even 2 or 3 from thousands come out with such thing. That too in a urban slum area. They say that we are the most immune, we won't declare. So imagine then how the utilization of service. So we need to do the sociology level of research to take these things forward. So to the finishing end, I'll also show the other domains, and last 5 minutes we'll cover these and finish it off. So we saw epidemiology, bacteriology, sociology, behavioral. This social and behavioral research, they do some kind of qualitative research, not only direct quantitative research, and they come up with some additional value points which should be considered by a program implementer or a doctor, whoever at various levels. Okay, let's look at the other 4 departments, what they do. Immunology and biotechnology, very advanced, very high tech. In fact, if you ask me questions in this, even I may not be able to answer because I'm totally a clinician, right? So this is one booming area which is coming in TB research or any medical research for that matter. So they work on identifying various biomarkers for not only diagnostics, for TB background. For example, I have an infection, whether I will break down and become a diseased person, TB patient. So I need a biomarker to find initially, then I can give some treatment. Phage therapy, put some virus or bacteriophages inside the bacilli and do some changes, that itself will work. So use that in a patient and make sure specified treatment happens. Again, very, very specific. These are all even not there in our country. Things are in very, developing stages where you guys can work. Genomics, we need to find out what gene mechanism is helping this organism to grow and we are not able to achieve elimination or NTB. Again, very high potential for health sciences people. We have a mutation catalog developed from our institute which says nearly like 2,000 or 5,000, they always say some number. So much of mutations happening within this organism which is causing drug resistance, and we need to specifically find out. So imagine such a small organism is producing so much of issue for us that we are getting scolding from ministries and Prime Minister why you are not able to eliminate TB. On the other hand, coming to, I could see many pharmacology people here. Clinical pharmacology, biochemistry. This is damn good. Finding out pharmacokinetics and drug level assessment of this drugs. For example, I give patient a treatment. Even after 2 or 3 months, he still is worse. He's not at all developing. What should I do? Either my drug is not working because resistance has come, or the dosage which I have put. For example, if I have to give you 500 milligram paracetamol and I give you a pediatric dosage of 250 milligram, it won't even respond. Same thing works for TB bacilli. I need to find out if this particular patient is getting enough drug. So I do this pharmacokinetics and other kind of clinical pharmacology tests to assess the drug level within the body, how much absorption, and they do a wonderful job, even not only for the research, even for the program. These things are being done by specialists. And any new drugs, when it comes, we need to do pharmacokinetic, pharmacodynamic studies to say that this drug is really doing good job, whether we can take it for translation into program. See, India is a place where 1.4 billion people are there and so many lakhs of TB patients are coming out. And if I do a wrong one, I can't change it. So much of money is involved, right? So all these paraclinical or health sciences studies have to happen for any change to come. Adverse event monitoring. When I do clinical trial, I want a biochemistry person with me to find out the lab parameters to say that these drugs are overreacting. He's having some kind of allergy, some kind of liver enzyme elevation. Without having them in my research, there's no point I can even touch this patient. I need to collaborate with them. So, in fact, if you would have seen now, whatever domain I mentioned, even for a single research, everyone should come together. Okay, all these 10 departments or 12 departments, they have to come together for that research to be successful. Statisticians, some will think. So we thought about health sciences. Where are statisticians and mathematicians coming inside? Again, they play a very important role. This is one potential area. Not everyone are good in maths. That's why we are in health sciences. And if you are good in maths, being a health scientist, right, then you are wonderful. So we should be knowing how to do statistical modeling, how to engage artificial intelligence, machine learning to get up whatever research I was speaking. So till now, whatever I showed at the patient level, implementing it. But in the background, just with the data, they'll be able to come up with some newer idea. and they'll also have required for any statistic analysis. Whatever PhD or PG program, without a p-value, you won't be submitting a report, right? So at any higher level of research, their role is important, and they are the most powerful people because they handle our data. Bioinformatics, another booming area. Again, very less knowledge for me, but very potential area. Any research area now, any research unit, for example, ICMR has 27 institutes. Everywhere they're looking for bioinformatician because they work on, they are like combination like mathematics, statistics, some kind of health knowledge, computer science, and in fact, just at the room level, they are coming up with the molecule discovery, no, drug discovery by using those knowledge and computer. Personalized medicine. I say that I want some personalized medicine for this patient. They are able to find through various modeling mechanism within their bioinformatics, and they are giving me, saying, this is the way you should treat this patient. So these are all future, developing. Many people are doing, but a lot of scope is there. Anyone interested, you can always go for bioinformatics. Yeah, I'm near my last slide. Health economics, all of a sudden I moved again totally to an economist. Okay, and in economics, again there's a portion of health economics. Just a matter of fact, in entire ICMR, where like many hundreds or even thousands of scientists are there in different institutes, but there's hardly one or two health economics who is there, health economic specialist who is there. Their role is to find out how much of cost if I put and what effectiveness I get. So cost effectiveness studies are being done. Any research, if I go and show my head DG, Director General of ICMR, or the program, or the ministry, they say, give me a health technology assessment, give me cost effective study. Only then I can put my money into it. Why should I waste my money if it's not going to be really helpful? So they do cost effectiveness studies for treatment regimen, diagnostic, any implementation method, and the big HTA department is there. So I'm finishing here. This is just for the institute. There are, I mean, being from ICMI, I'm saying that there are a lot of chance that grants have been included. Look at the number, from 3 crores to 30 crores, fund will be, budget will be given if you write a good proposal under a specified theme. Okay, it's open for all institutes, not only, I mean, Dayanand Sagar University can use it. Only thing which they look is, okay, of course, multiple people will apply, but you should be smart enough. It should have multidisciplinary collaboration, multi-centric, not only in this institute. The institutional capacity should be good. I think DSU has enough thing. And that proposal should have a translational value. Only then you will get this. So this kind of idea you have at even a student level or a junior faculty level, you can do wonders for this country. So thank you. This is my institute. If you guys want to send your students or anyone interested, you can contact us. Wherever it's feasible, we can do a collaborative research. Thank you. Thank you for the patient listening. Any questions? It goes.
Check. Yeah. Any questions from the audience, please?
Thank you, Dr. Balaji, for this comprehensive talk regarding the tuberculosis and which all departments can come together for the research. I have two sets of questions for you. One is, I was earlier working, I am a medicinal chemist, and drug designing, bioinformatics is a kind of things which we can do. So there was a point of time when we were working on the
Can you keep your mic close?
Yeah. So there was a point in time when we were working on tuberculosis, and we designed certain new molecules and tried to collaborate with many people from the government institutes to test the TB. But nobody was helping us, right? We were not getting any positive response from anybody.
Ma'am, where are you from?
Dayanand Sagar.
Okay, okay. Medical college or what you said? You
No,
are
sir. I'm in a pharmacy college. I'm a
Yeah,
professor
got
of
it.
medicinal chemistry here. So we have PhD students who work on all these things. So I want to know that how much you are open for the private universities to collaborate like this.
Okay. So yesterday there was, I mean today also it's going on. Okay, I'm just landing from Delhi. There is an ICMR, the DHR summit, where they identify people who come up with such things, right? We also had an innovation summit because you were mentioning TB. So multiple platforms where I personally saw so many private partners who have come up with such ideas, and if it was proving to be useful, if the government is convinced that funding for such research or development, looking at the TRL level, at which stage you are, 1, 2, 3, whether it's worth spending there, whether such technology is not already there, every assessment is done, right? Even for a simple student level research and all, we do get thousands of application, and from that, there are a lot of screening happening. It's not that every 1,000 of them will, hardly 10 to 15 will get. So this is one thing from government where they have some restriction, but we should not stop at that. That's my point. Okay, we should think about other further way of doing also, because government is not the only partner which will be doing. If government support is not reached, then we can try to reach a private partner, because again yesterday I saw a team which has worked, which has developed some kits and other thing. They gave it to a private partner to produce more and see at a larger level. Okay, again, sometimes when we find a research finding at a smaller level and it's not convincing, we need to show them at a more valid group with more power, with more rigor in your methodologies to show that this is wonderful. So a lot of efforts are required. In fact, being from ICMR, it's not so easy for me to get a fund. I need to fight like a PG student, defending my thesis, saying this is what, only then I can get fund either from India or like Bill Gates Foundation, wherever. So things are there. It's not so easy. We need to be really tough and competitive.
Yeah, and it's more so for the private institutions, I believe, rather than the government institutions.
Okay.
Since ICMR is looking for translation and research, so people like us are into basic research. Everything may or may not get translated. So we have very few funding agencies to support us. That is our main problem actually.
I do agree, ma'am, that we need to lead in the race. That's the only point. It's not that private is not accepted, because one category was only for private. If you look at ICMR, you would have seen that extramural research. Previously, even we compete in extramural research, but the current DG has clearly said, you guys are already in ICMR. You can't compete for that. It is only for the other universities, and plenty of private partners are working, ma'am. There's no doubt. I saw yesterday also so many awards being given. So many young children are coming up with so many ideas, and it was encouraged. So we need to keep trying. That is my point. I'm not saying that it's not already well developed or ICMR is taking everything. We need to keep looking at the right platform and try to get it. That's the only answer I have. Yeah.
Thank you.
Any other questions? All right. So I think I must really congratulate Dr. Balaji for this wonderful presentation on a very difficult topic. Acceleration and collaboration. Most needed for us to defeat, destroy and decimate this disease called tuberculosis in our country, and we need to have a very duty-bound and disciplined approach. So you have covered almost every single gamut of things that one needs to do from a multidisciplinary, multi-pronged approach. So thank you very much for your insights today. We're very grateful to you. Request a very generous round of applause for Dr. Balaji, please. Thank you very much.
Thank you so much.
Thank you so much, sir, for your nice and informative thought over the bioinformatics, and we got many insights. I kindly request Dr. Pushpa Sarkar, Madam, Dean, School of Health Sciences, to hand over memento and certificate of appreciation to Dr. Balaji. I request Madam to hand over memento to our chair session, Dr. Guru Prasad.
Delegates, please note, 6 o'clock we will start with the grand gala dinner and cultural extravaganza. So please stay back. 6 o'clock we are starting with a musical night and gala dinner. So after tea break, so half an hour will be there for you. Just relax to enjoy the cultural show and musical night. Right? Thank you.
Come down, I said, your certificate is printed, you better collect it.
You have to earn it.
Yeah, I will not give that. Get the certificate, sir.
With DJ.
We will be having the Chudik Arulappa, Associate Professor, Director, Nursing Laboratory and Simulation Unit, College of Nursing, Sultan Kuwait University. Dr. Raghunathan and Dr. Garima Patel, Senior Physiotherapist and Physiotherapist, Anand Foundation student, Specialist, Neuro Rehabilitation Stroke, East Physiotherapist. We will have Dr. Umar Ani, Principal and Dean, D.Y. Patil College of Nursing, D.Y. Patil